Thank you very much, Michael. Good afternoon, everybody. So, as the other speakers, I'm very happy to be in Athens for this conference, and it is very successful. Outside it was raining today, so it is good to listen to the lectures. And all the lectures I listened to yesterday, this morning, and this afternoon were very excellent. So, my disclosures, I'm a member of the Medical Advisory Board of Pulsion Mackay. I gave lectures for Edwards Life Science in my Swan-Ganz catheter period when I was young. And I also gave lectures for Massimo. So I will speak about transpulmonary thermodilation systems. And we have now some devices. The Pico and the volume view devices, and we have the PulsoFlex platform able to track the Pico signal. And you know that these systems are connected to the patient through two catheters. One is a central venous catheter for injecting cold bolus and to obtain thermodilation variables. And the other one is the femoral artery catheter with a thermistor to record the changes in blood temperature which are produced by the cold bolus injection. And you know that if you inject a cold bolus in the blood through the central venous axis, you can have a dilution in the right atrium, right ventricle, pulmonary compartment, left atrium, left ventricle, and you can record the changes in blood temperature at the level of the femoral artery. And there is some thermodilation curve which is built by the machine, and we know from the Stewart-Hamilton principle that we can obtain a cardiac output from this thermodilation curve, and this is what is done by all the systems, these systems. And of course, cardiac output measured by transpulmonary thermodilation was validated against the PA catheter thermodilation cardiac output, and this is one of the first studies doing this by Saka and co-workers, and they found a good correlation between cardiac output measured by the Swan-Ganz catheter and cardiac output measured by the Pico here. And also they found a good agreement between these two measurements and using the Bland-Altman analysis, and they found that the percentage error, this morning Thomas Sharon spoke a lot about the percentage errors, and in this case it was good, it was 16%. So you okay, I will just comment on my slides. So I said that there was a good validation and good percentage error between cardiac output measured by transpulmonary thermodilation and cardiac output measured by simple thermodilation. And a question which can arise is, what is the precision of the transpulmonary thermodilation method? And for this, with my colleagues in my unit, with Xavier Monet in particular, we try to answer this question by, yes, this is this question, good. by measuring, by trying to find the number of cold bolus injections that are necessary for achieving an acceptable level of precision for measuring cardiac output. And finally, we found that we need three boluses of 15 ml to be injected to have a sufficient precision. But of course, these systems that speak about the transparent thermodilution systems are not just cardiac output monitoring systems. They can measure many, many other important variables coming from the transparent thermodilution and also coming from the pulse contour analysis, because of course you have an artery catheter and you can have the pulse contour analysis, the cardiac output, PPV, SVV, etc. What about global and diastolic volume, which is another variable in addition to cardiac output? GEDV is a good marker of global cardiac preload, and it is in fact the sum of the maximum size, volume of the 4 cardiac chambers: right atrium, right ventricle, left atrium, and left ventricle. And if you use a pico, this is measured by this variables, DST, downslope time. If you use a volume view, it is another way to calculate GDV, but the results are more or less the same. And a question which can arise is global and diastolic volume really a marker of preload, a volumetric marker of preload? The answer is yes. With Frédéric Michard in the past, we tried to answer this question, and we gave fluids or we gave dobutamine to 2 different groups of patients. And for fluids as well as for dobutamine, cardiac output increased. But only for fluids, GEDV increased. For dobutamine, this did not change. GEDV did not change. So, in fact, this study brings some arguments to think that GEDV behaves as a marker of preload, because it does not increase with dobutamine, but it can increase with fluids. And others, Chris Hofer and co-workers, look at the changes in global and diastolic volume index measured by the PICO here, and the changes in the left ventricular endoscopic area index measured by echocardiography. And they found a nice correlation in spite of the fact that the left endoscopic area measures the preload of the left ventricle only, and the GDV is a global marker of preload. What are the normal GDV values in ICU patients? It's a good question, but the best question is what are the usual GDV values in ICU patients? In fact, this is a very, very wide range of normal values if we consider the non-surgical critical ill patients. Non-surgical critical ill patients, you can see that on the left you have the studies, and on the axis you have the volume of GDV, the values. And you can observe that according to some studies, the volume, the normal or the usual volume can be very different with a very large interval. And in some other studies, it was small. So in fact, the average, but I don't know if the average value means something here. The average of the average is around 800 ml per kilogram. And in surgical, non-critical ill patients, it is a little different, and the normal or the average of the average values is around 700 ml. What are the limitations of GDV? In fact, we know that GDV could overestimate left ventricular preload in case of dilated right ventricle, of course, because it is a global marker. So you can have some high values in case of RV dilation and a normal left ventricular preload. Another limitation, and we spoke a lot about this today, is that GDV is a poor index of preload responsiveness because it is considered a static measure of preload. And this is confirmed by this meta-analysis by Volumetric, published some years ago, and he paid attention to many variables, including GDVI, in this meta-analysis, and as well as for CVP, the ROC curve is only 0.56. Why? Simply because a given value of preload, in this example of GDV, can be associated with preload responsiveness or preload unresponsiveness, depending on the left ventricular or the global ventricular function. In case of normal heart, you can have preload responsiveness. In case of failing heart, you can have preload unresponsiveness. So you cannot know, in fact. Another important transpulmonary thermodilation variable is extravascular water. It is important because it can give you a quantitative measure of pulmonary edema. And the normal value is considered to be less than 10 ml per kilogram. And this was the way to obtain this value inside the machine. Either the pico, the pulsoflare, or the volume view is very complicated, but we don't care about this. If you want to have more details, you can read some papers like this one, coming from our group, others also. This value was well validated by a study from Japan, and Takashi Tagami was the first author, and they measured extravascular water using the PICO just before the death of the patient, in moribund patient, of course, and because they did not sacrifice patients just to measure lung water. And they measure lung water before the death, and they look at the lung after autopsy, and they look for some what they call diffuse alveolar damage in the lungs, and they found that patients with DAD had higher extravascular water just before death than patients with no DAD. And they found, using a ROC curve, a good sensitivity and specificity for a cutoff value of 10 ml per kilogram. It's fortunate because it is easy to remember. I will skip this. There are some limitations of using extravascular water in theory. In theory, there is a poor distribution of the thermic indicator in non-homogeneous ARDS lungs. So in this case, you should have some, I would say, underestimation of extravascular water, the true extravascular water, just by measuring this variable. But in practice, it's not true, and many ARDS studies show that extravascular water is a good marker. And for example, in this study with Mathieu Josbiak and Xavier Monet in our unit, we showed that in 2,000 patients with severe ARDS, we showed that the maximal value of extravascular water during the stay of the patient, the maximal value, was an independent predictor of mortality in these patients. And this, in spite of the theory, which is that there is a poor distribution of the indicator in the lungs, in non-homogeneous lungs. And also, this was confirmed by others. This is, again, a study from Japan, and showing that extravascular water over time can decrease in survivors and to be unchanged in non-survivors. And they found that the cutoff value of 2.8 for lung water can well separate the survivors and the non-survivors, the changes in extravascular water, not the absolute value, but the changes above 2.8, the decrease above 2.8 was associated with a better survival compared to patients who did not decrease by more than 2.8 the extravascular water. This is an interesting study performed years and years and years ago, because the paper was published in 1992, 25 years ago now, and it was a randomized study comparing two strategies. One was based on wedge pressure, POP, and one was based on extravascular water. So fluid management was based in one group on POP and in the other group on extravascular water. As you can observe, the cumulative fluid balance was better maintained in the extravascular water group compared to the POP group. So this is good news because we know that the cumulative fluid balance is not a good thing. It is always associated with increased mortality. And also, more importantly, they show that the duration of mechanical ventilation and the duration of ICU stay were shorter in the group of patients managed according to extravascular water compared to the other group. And many other studies showed that there is a good, how to say, that extravascular water was associated with increased mortality, either in the general critical patients or in septic patients or in ARDS patients. Many studies show that the higher the extravascular water, the higher the risk of death. And this independently of the other variables. What about the pulmonary vascular permeability index, which is another marker of which can be provided by the transpulmonary thermodilation device? I like this marker because it can tell us about the lung capillary leaks. It's a good marker of this. And it is automatically calculated by the machine. You have nothing to do, of course. And PVPI could be used to distinguish between hydrostatic and increased permeability lung edema. And this is a study we did with Xavier Monet in our unit some years ago, and we studied patients with ARDS, and at that time we also had patients with acute lung injury, but now we can say ARDS, and patients with hydrostatic pulmonary edema, and we found that a value of PVPI of 3 can well distinguish between these two categories of lung edema with a good sensitivity and an excellent specificity. And it was better than BNP. You know BNP, this famous biomarker which is used every day in every department. And in fact, PVPI is better to well detect hydrostatic pulmonary edema compared to BNP. Again, Japanese study, Japanese group, there were many authors, and they found that PVPI was higher in ARDS compared to cardiogenic pulmonary edema and compared to pleural effusions with atelectasis. And they also found that the PVPI cutoff value of 2.85 was the best one in their study to distinguish between ARDS and the other categories. And it was very close from the value we found, which was 3. But I prefer 3, it is easier to remember. And also in this paper, they found that if we take the Berlin definition of ARDS, mild, moderate, and severe ARDS, PVPI well follows this definition. PVPI is higher in moderate compared to mild and higher in severe compared to moderate. And also in this study I already mentioned, we found that PVPI, the maximal value of PVPI during the stay of the patient was an independent predictor of mortality. So it makes sense to measure it. CFI, cardiac function index, it is also provided by the transpulmonary thermodilation, and it is considered the index of cardiac systolic function. It is automatically calculated and displayed on the screen of the monitor. And with Julien Jabot, in our unit, we tried to address the issue of what is the meaning of CFI. Is it really a marker of contractility or systolic function or not? For this, we gave fluids to some patients, and we gave dobutamine to other patients, and we found that CFI increased only in the dobutamine group and did not change in the fluid administration group. So it makes sense again, and CFI will behave as a marker of systolic function, as expected. But we also compared CFI on the y-axis and LVEF measured by echocardiography on the x-axis, and we found a good correlation. It cannot be a perfect correlation again because CFI is a global marker of systolic function, including the right ventricle and the left ventricle. And by definition, left ventricular ejection fraction only measures the systolic function of the left ventricle. But a value of CFI less than 3.2 is a good indicator of a very low LVEF, less than 35%. So in our unit, we use CFI as a warning variable, and when we have a low CFI, we are encouraged to perform an echocardiography to confirm first, but also to try to find which is the mechanism responsible for this decrease in the systolic function. And also we found in this study with Julien Jabot a good correlation between the changes in CFI with treatment and the changes in LVEF with treatment. So repetitive measurements of CFI allow following the changes in cardiac function with therapy. Some words about pulse control analysis, just to say that it is possible from these systems to have a continuous cardiac output monitoring in a real time, because you know that the Swan-Ganz catheter can provide a continuous cardiac output monitoring, but not in a real time, This is the advantage of all these pulse control analysis systems. And it is useful to perform dynamic tests. We spoke about fluid challenge, we spoke about passive leg raising, and expiratory occlusion test, and you can follow the changes of cardiac output using this pulse control analysis. You do not need to inject cold bolus to perform transpulmonary thermodilation measurements. It's not necessary. You have just to look at the changes in continuous cardiac output. Yes, but I was a technical problem. So no, it is 2 minutes for without technical problem. No. 1 minute more. Also, you can have SVV and PPV. Just to say that you know that PPV is associated with preload responsiveness when it is high, and when we have no large PPV, in general it is associated with unresponsiveness, and I don't want to describe this because it was already described. And from these studies we did many years ago, and we proposed to use PPV, and it was better to predict fluid responsiveness than the cardiac filling pressures. And this meta-analysis, including 22 studies and 800 patients, PPV was shown to be good to predict fluid responsiveness. You see the area under the row curve was 0.94 in this study. In patients with tidal volume above 8 ml per kilogram, I want to precise this, and the threshold value was 12%. Also, it's possible from these systems to obtain SVV, strong volume variation, of course, and it's also a good marker of preload responsiveness with the area under the row curve of 0.84. Of course, we have limitations. We already spoke about this, so I don't want to go into details. And in this situation of limitation, you can use other tests like passive leg raising. So I want just for the last 2 minutes, I want to address this important point. How should we use transpulmonary thermodilation systems? My opinion is for guiding fluid management in patients with shock and ARDS, because we can well assess the benefit-risk ratio using these systems. In fact, we can assess the benefit, which is a numerator of the ratio, by looking at PPV and SVV, and in case of, if PPV and SVV are not valid, low tidal volume or arrhythmias, etc., we can look at the changes in pulse control cardiac output in response to either passive leg raising or an expiratory occlusion test. And this is good for the prediction of fluid responsiveness, and this is a numerator of the fluid infusion benefit risk ratio. And the denominator also can be provided by extravascular water and pulmonary vascular permeability index. We can be very useful for assessing lung tolerance to fluid infusion. So you have the numerator and the denominator just in front of you, and you can decide. You can decide to start, to continue, or to stop fluid infusion, which is very practical. And this is what we propose in the paper already mentioned by Thomas Sharon this morning. We propose to measure, to use the transperimetry thermodilution systems either in case of refractory shock, and someone asked the question, what is a refractory shock? In fact, in our opinion, it is a shock that does not respond to the initial therapy, which was based on other clinical assessment, on echocardiography, arterial catheter, and central venous catheter variables. Or also we can use it in case of severe ARDS at the beginning. If you have shock plus ARDS, this is a good indication for transpulmonary thermodilution system use. So my conclusion is that with this system, we can have many variables, and we can have a complete picture of the hemodynamics of the patient, and we can have good arguments to make decisions. Thank you very much.